Yeah, she did.
I'm gonna try it out with her. You came and said hello.
Sorry if you hear my mucus.
No, you're good.
Hello?
Yep.
Hey, then did you want to be in this right now, or are you good?
I'm at work right now.
Okay. Well, I'll try to do another one later. Just let me know. But
Okay. Who's on
all
right now?
right. So Eunice, Kathy, Alejandra, Shelly, and Ava. Is that Ava?
Okay.
Eva.
I will try to join silently on the computer then, but I probably won't be able to participate. Just listen in.
No, you're good. It's not really
Right.
like review. I mean, if you guys have questions on stuff later, you can do like a personal one or
Okay. All right. Thank you.
so, so we can follow up with Brown or another tutor or whatever. But I'm just gonna give like what she said to focus on. So when she did that review, she went over all the chapters or just some of them.
One chapter each video recording. So I think there's 4 recordings. Is that right, Eva? I'm not sure. I didn't
Yes.
check the last. I didn't check the last recordings.
Yeah, I haven't had time to do the last to check out the last one she sent out.
All right. So y'all who are reading here, can y'all hear me? Okay. So let me know if y'all can hear me
Yep.
before I get started. Kathy, can you hear?
Kathy said um, Brown is only reading the slides.
I'm just gonna keep the notification. That's what Kathy said. Brown's only reading slides
Yeah.
in the review.
Yeah, it wasn't a review. It was basically lecture. You know how teachers just read the slides? And then she would give pointers.
Okay. All right.
Oh, Kathy has no voice. She sounds probably worse than me.
Okay. I got you. All right. So if your ears are ringing and it's driving you crazy, what is that?
Tinnitus.
Okay. So you have someone who's over the age of 45 and they have impaired vision. What optical disease is that? What disease is that?
Presbyteria
Oh,
or
perfect.
presbytopia. I
Perfect.
just I just know Presby is old.
Yep, exactly. But it's the auditory one or the visual one, presbyopia. It's the elderly. So there's like no other, there'll be no other like diseases with it. It's just basically because they're elderly and their vision is waning. So presbyopia. Good. Um, what is hyperopia? What is hyperopia?
Uh,
So hyperopia is you
farsighted.
see this farsightedness. So you can see distal vision well, but your eyes cannot focus on close things. Okay, and then myopia is the exact opposite,
Nearsighted.
nearsightedness. So you can focus on near but not far. Okay. Um, the retina is in the inner posterior of the eye. So the inner back of the eye. The retina, inner posterior. And that's where your light sensors are. That's where your light sensors are. The lobe of the brain responsible for vision would be opposite vision. The goal of glaucoma treatment is to lower the IOP, the intraocular pressure by any means. So surgical or farm, technically. So medicine or relieving the pressure by surgery. That's the goal of glaucoma, of course.
Did you say that was the goal for intraocular pressure surgery?
No, the goal of glaucoma treatment is to reduce IOP, intraocular pressure.
Oh, right, right.
So either by medicine or surgery. Okay. The leading cause of childhood blindness will be premature retinopathy. And there's different types. I don't think she went in depth for you guys, but just premature retinopathy. All other causes are they're like rare. This is the leading cause. So your receptors of sensitivity can be altered by environmental factors. The most common or the most significant would be cigarette smoke, especially like taste receptors of sensitivity. So the risk factors of glaucoma would be age, steroid use, like over a long period of time, being African American, eye trauma, or diabetes. Are the risk factors for glaucoma. So risk factors for fibromyalgia would be like depression, clinical manifestations of fibromyalgia would be like depression and neuropathies, but dizziness is not one of them. It doesn't affect the central nervous system. So dizziness would not be a clinical manifestation of fibromyalgia. What are pain receptors called?
The neuroreceptor. Sorry,
Yeah, they're nociceptors.
nociceptors.
Pain receptors are nociceptors. Yeah, it's kind of right. The other ones, it's the only like weird one you should talk about. The other ones kind of make sense, like thermoreceptors, chemoreceptors, but nociceptors is like the only weird one. It's okay. So preventative treatment for migraines. You want to know like who like could basically be identified for this type of preventative treatment. Everyone else basically gets palliative treatment, like NSAIDs and stuff. So to get the preventative treatment, it's highly surgical. But there's like other medications, like beta blockers and stuff, used as an adjuvant. But patients who like qualify for that would be just think about any complicated migraine. So if your migraines are not fixed by common medications, so obviously it's about kind of complicated. If you have more than 3 migraines per month, if you have to use those pain meds, so it does work, but you have to use those pain meds more than 3 times per week. If you have uncommon migraines, like ones that really don't have a pattern or like intensifying severity, so just think the threes. So having them 3 times in a month, having to use pain meds to relieve them 3 times in a week, and then uncommon or ones that can't be helped by medication. So medication doesn't touch it. You can even do like even ones where you have what's it called, that injection, like Botox, you do with migraines. So these are uncommon methods, so they qualify for preventative. Okay. All right. So know the structural components of the ear. In specific, the semicircular canal is responsible for balance and equilibrium. So that's like the main guy for balance and equilibrium. Although a lot of your inner ear helps with it. Signs and symptoms of Meniere's disease. Hallmark would be vertigo. Right? That's the disease of the inner ear. So vertigo. All right, so your pain theories. So you know the gate control, that's like the most common one we use in medicine, but pattern theory is basically that the intensity of the stimulation or how you feel it comes about from um, the overall intensity of this, sorry, the intensity of the perception of pain comes around from the intensity of the stimulus or the location of the stimulus or the duration of the stimulus. So basically what it's saying, it kind of makes sense pattern. So how long my hands on the stove or how hot the stove is for me when I touch it, that indicates how much pain I'll feel. So the pain that I perceive follows the pattern of the stimulus. All right, so if the stimulus is closer to my central nervous system, so say my upper arm versus my fingers, if it's on me for 5 seconds versus 1 second, if it's more frequent, then these all increase your pain, and that's a pattern theory. So decreased serotonin is not a cause of migraines. Anything causes migraines, lack of sleep, lack of nutrition, lack of hydration, but decreased serotonin is not. Even though you can treat it with some adjuvants that increase your serotonin, that is not the cause of migraines. Decreased serotonin, not the cause. So if you had decreased hypothalamic function, you would expect to see hormone deficits and loss of hormone function. Hypothalamus is the gatekeeper, so majority of hormones are triggered or cascaded from your hypothalamus and the pituitary. So if you have decreased hypothalamic function, you expect to see hormone deficits and loss of hormone function. The stress response is coordinated by the central nervous system. It's coordinated by the central nervous system. There's like different components and different pieces of it. You might have to learn it for med surge, but for now, just know it's your central nervous system, hypothalamus, amygdala, but it's all in the CNS. Stress response. So the release of hormones from glands is controlled by negative feedback. Negative feedback. Okay, that's basically every hormone except like 2, and you'll learn about those in like OB. So the only like positive ones would be like oxytocin. So basically, because like you're in contraction, so you're telling your body to have even more contractions for the baby. But every other hormone is controlled by negative feedback. Okay. Speaking of hormones, they are chemicals which are formed in tissues and they affect other tissues or other cells. So one tissue makes a chemical, releases it to stimulate another tissue to do its job or release even more chemicals. Mm-hmm. So diabetes insipidus, it is insufficient or you have a decreased amount of anti-diuretic hormone. Yeah, so diabetes insipidus is insufficient ADH. So if you get stumped on that one, between diabetes insipidus and SIADH, symptoms or syndrome of insufficient antidiuretic hormone, basically just think, your diuretic hormone makes you urinate more, release water. Antidiuretic makes you hold water. All right. So in diabetes insipidus, you have insufficient ADH, so you will be releasing water, peeing all the time, clear water. Right. You always feel thirsty, always drinking, polydipsia, polyuria, diabetes insipidus. The opposite, SIADH. All right. So your body has too much antidiuretic hormone, and you're retaining a lot of water. So it's all about the diuretic hormone. Most common cause of hypothyroidism, I'm pretty sure what she was trying to say is another form, the most common form of hypothyroidism will be Graves' disease. But yeah, most common cause of hypothyroidism, Graves' disease. Hypothyroidism. And then low thyroidism, you can see edema in the face, in the hands and the feet, caused by a protein, specific protein, and that's known as myxedema. MYXDEMA. Right? So when you see that edema basically all over from hypothyroidism, and it's caused by a specific protein, that's called myxedema. So hyperthyroidism, basically sum it up, hyperthyroidism is like your thyroid's obviously hyper, excessive production, right? So your thyroid helps with like thermal regulation, metabolism. Just think everything's high and fast. You're losing weight, you're sweating, you're just hopped up. And then hypothyroidism is the reverse. So you're gaining weight, your metabolism is low, you're cold, so you have a cold intolerance. It's basically just the opposite of each other, which makes sense. Okay.
Mm-hmm.
So you have abdominal pain, and you want to be able to kind of describe what type of pain it is. Okay. So in visceral pain, it'll be diffuse and generalized. Visceral pain will be diffuse, generalized, kind of radiate. So visceral pain is like your organs. Like nobody can say, "Oh my gosh, I feel like my upper colon hurts." You just be able to be like, "Oh, it kind of hurts in my stomach." So it's general, it's diffuse. If your colon hurts, then maybe your small intestine hurts. So it kind of radiates. It's all under one track. Your organs kind of affect the next. So it's generalized. All right. Referred pain is just pain that's caused in one region and then recognized in a distal region. I'm having a heart attack and I have neck pain or shoulder pain, or you're having cervical pain and now your left shoulder hurts. So it's referred somewhere else, somewhere distal. And then somatic will be sharp and intense, and it's localized to one site. So of the different types of pain, somatic will be like the most localized because it's just body pain. You can clearly be like, it's like body muscle joint, right? I can clearly be like, my left elbow hurts. I wouldn't confuse it with my whole arm. I can clearly tell you my finger hurts. I wouldn't have to confuse it with my whole upper arm. So somatic is sharp and intense. That's why you can clearly tell, like, this exact point right here hurts. And you wouldn't confuse it with another one. Visceral will be diffuse, radiating, more generalized. And then referred, obviously, I think the easiest of them is I have pain in my head and now it presents somewhere down here, somewhere distal. All right. Exophthalmos, EXOPTHALMOS, like the bulging eyes, bulging eyeballs. Weight loss and agitation, just like we said before, that'd be like hyperthyroidism, so Graves' disease. That would present in Graves' disease, which is the most common form of hyperthyroidism. Exophthalmos, weight loss and agitation. Just think like you're hopped up, everything's more. Eyes bulging through pressure, agitated, you're on edge, weight loss because your metabolism's on fire. So that'll be Graves' disease. And then the opposite, dry skin, weight loss, and cold intolerance will be signs of hypothyroidism. Low thyroid, hypothyroidism. Okay. The patient is in fluid overload. What would tell you that this is because of SIADH, syndrome of insufficient antidiuretic hormone? And then it'll be the excess production or release of ADH, like we said. So SIADH is too much ADH, diabetes insipidus is too little. So ADH became
Sorry.
You have a question?
No.
Oh,
Sorry, my kids were screaming.
Very good. Okay, excess production or release of ADH. Okay. So you have excess glucocorticosteroids or corticoids, and a buffalo hump and a moon face. All right, those are hallmarks of Cushing's disease. A buffalo hump, the round moon face, and it's caused by excess glucocorticoids or glucosteroids. Right? Cushing's disease. Okay, so you should know gas or general adaptation syndrome and the three stages of it. First is the alarm. So basically, it's when your catecholamines, like dopamine, epi, the guys who respond um, from your sympathetic nervous system, and then your cortisols respond to the stimuli. All right, so in the alarm stage, first you have the hormonal chemical response to whatever's triggering you, whatever the stimuli is. All right, then after a while, that continued, you develop the resistance stage. In the resistance stage, your cortisol decreases through negative feedback. All right, so you've been alarmed for a while, you've been on edge for a while, and now your cortisol will start to decrease. Even if that threat is still there, your body will say there's enough cortisol released in your body already. This is enough negative feedback to stop producing it. So that's why it's like resistance. Think of it of like the what's it called? Alarm fatigue in a hospital. At first, you're like, oh my gosh, what's wrong with my patient? But after like 4 hours or weeks on in the ICU, you don't even notice anymore. So your body's like, whatever. The stimulus may still be there, but at resistance stage, we're going to stop producing that response or lower that response. And then exhaustion, just like it sounds like, the final stage is you've depleted your body of the chemical messengers or the hormones, the catecholamines, and the energy. And just like it sounds, you're exhausted. Right? So that's why you shouldn't be in a hyper stress state forever. You have decreased wound healing, decreased focus, all sorts of things. So the alarm stage is the initial response with the catecholamines and the cortisol. In resistance, the cortisol begins to lower through negative feedback. And in exhaustion, you have an energy depletion within your cells of energy and everything. Insufficient ADH results in polydipsia and polyuria and severe dehydration. What is that disease? Let's describe. The disease where you have insufficient ADH, so you're not holding on to enough water, and now you have polydipsia, so you're super thirsty, polyuria, and severe dehydration.
It's the SAID. That's the said one. Or
So
is that what you're talking about?
it'll be actually diabetes insipidus.
Oh, the
So you don't
opposite
have
to
enough
Cushing's.
ADH.
Is it the opposite to Cushing's?
It's the opposite to SIADH.
Oh, right.
So, yes, just think about whichever is easier for you to imagine, just realize they oppose each other. Okay? So, diabetes insipidus is the one where you don't have enough antidiuretic hormone or vasopressin, so you urinate a lot. Okay? You urinate a lot. Pure, free water. SIADH, you have too much, so you're not urinating as much. You're retaining water. So whichever is easier for you to imagine, just know that they're the opposite. Does that make sense?
When you say you have too much what?
ADH.
ADH.
And diuretic hormone. Antidiuretic hormone. So for me, even though I've memorized them and heard about them, I still have to break it down. So whatever works for me on the test, I always have to sit there and start at diuretic hormone. Okay, I know a diuretic makes me pee more. So an antidiuretic makes me not pee more, hold on to water. So if holding on to water, that will be SIADH, which causes me to hold on to water. Too much ADH. I know diabetes, we have polydipsia, polyuria, so I'm urinating a lot. So I don't have enough ADH. So you have to trace it back, do that, or if you can memorize one, just know the other one is the opposite. Right? So insufficient ADH, polydipsia, polyuria, and severe dehydration because you're flushing out is diabetes insipidus. So in Cushing's disease, we have that elevated cortisol, Cushing's disease. And that's kind of why I remember like Cushing, you get cushy, you get puffy, you get swell. The excess amount of cortisol causes water retention. So to diagnose this, you have elevated cortisol. You have to do a 24-hour urine collection for the cortisol specifically. 24-hour urine collection to test for elevated cortisol. That's how you diagnose Cushing's. Yeah. To know your diabetes, specifically your diabetes mellitus, is well controlled. Your hemoglobin should be under 6 point, it could be 6.5 or less. So you're looking for 6.5 or less percentage. Okay. That should be well controlled diabetes mellitus. That is the testing that we do, or you can see it abbreviated as HbA1c. It's better than a fasting glucose or random glucose. They have different levels, but this one shows you compliance over 3 months, or how their body was exposed to sugar over glucose over 3 months. Right? Anybody can come to the doctor's office and be good for that day, can put down the soda for the day, you're random or fasting glucose, but HbA1c will show your exposure to glucose over 3 months, basically your compliance. Okay? So that should be under 6.5, that's well percent. Okay. If your patient has metabolic acidosis, we're talking about diabetes, of course, but metabolic acidosis, and they're diabetic, you can basically attribute that to DKA. Okay. Fat breakdown, that's where those ketones come from, might present urine, and lack of insulin. So the number one cause of DKA will be because they're not insulin compliant. So if somebody comes in, basically they've had a lack of insulin, they've had metabolic acidosis, and they have fat breakdown for energy now. They're in DKA, diabetic ketoacidosis. Okay. So you have a compliant patient, they're always looking at their glucose, and you want to check, basically their glucose is rising all the way from nighttime to morning. Right? It's rising basically when they go to bed all the way to morning, steadily, just steady rising like this. This is called the dawn effect. The dawn effect. Okay. So they're in typically good control of their glucose, but from the time they go to bed to morning, you can see the increase all the way to a hyperglycemic state. This is dawn. So I remember it like basically at dawn, you're having a increase all the way until dawn, and now you're hyperglycemic. All right. And then the other way, the other effect will be Somoji, and basically that is, it has the same result. You end up with hyperglycemia in the morning, but around 3 a.m. in the middle of the night, there's a severe depression, hypoglycemia, and then it rebounds back up. Okay, so she's still working on these, but basically you just have to know the hallmarks between them. So if you distinguish between dawn and Somoji, Somoji has that middle of the night around 3 a.m. hypo, low sugar incident. After that, it'll rebound back up.
Is that why with those patients we're supposed to give them a snack before bed?
Yeah.
Right.
So these are the causes of why each. So I'm not sure how deep she'll go into. She's still kind of formulating those. But dawn, just think of dawn. You have a down amount of insulin, so like a little bit. So either you didn't have enough insulin before going to bed for coverage over the night, or you took your insulin too early before you went to sleep, and now it's not affecting you all the way through the morning time. So basically think your insulin's wearing off or it's weak, so it's just a steady increase. It's wearing off, so you're slowly increasing until you're hyperglycemic in the morning. So it could be a snack as well. Snack will be more so Somoji. All right, and then Somoji, if you're looking at the cause, it'll be more so you had too much insulin. So Somoji, you had so much insulin. Somoji, so much insulin. You had too much insulin or took it too close to basically you going to sleep. So now it declines into hypoglycemia. You crash into hypoglycemia by like 3 a.m. because you took too much insulin before bed or too close to sleeping. and then you have now plummeted to hypoglycemia, and then your body basically rebounds and reacts and it's like, yo, I have too low blood sugar, let me bounce it back up. So that's why you end up with the rebound hyperglycemia in the morning. So both will have hyperglycemia in the morning, but dawn will lead to a down amount or a low amount of insulin and just a steady increase. No decrease in dawn. Just steadily increasing all the way to dawn. The morning time. Is dawn morning time? Yeah, dawn. Okay. And then Somogy will be you had so much. That's SOMOGY, something like that. So I had so much insulin that when I went to bed, I was okay, but then somewhere around 3 a.m., I became hypoglycemic because the more insulin, the lower my sugar is. And then my body's like, hey, let me correct this. And then I snap back up, hypoglycemia. So the only definitive way to know what the reason is, like I said, they both end up here, hypoglycemia, is to do like a 3 a.m. check. All right, that's the only hallmark between them. You can suspect if, one, you didn't have enough insulin, you can suspect one, you took too much insulin or too close to dinner or didn't have a snack for coverage, but the definitive test will be to test your blood sugar at 3 a.m. So just kind of know that, I don't think she's sure where she's going yet with that. But that's basically the two different effects in a nutshell. Okay? We talked about hemoglobin A1C depicting your glucose exposure or your compliance over 3 months. Micro, so small microvascular damage from diabetes mellitus will cause damage to your eyes and to your kidney. Is she guys' classmate, Nicole?
Yeah, she's trying to join.
Hey, Jesus.
Yeah, sorry, she's trying to join.
Yes, she's in my group.
You good?
I just added her. Hey, Nicole.
Hello.
Hey, can you hear me?
Yes. Thank you.
Alright, well, alright, we're gonna continue from here. Alright, so microvascular, like I said, will be, like it sounds, small vessels. So this will be damage to your eyes and your kidneys. Okay? That's why you always hear about renal failure and glaucoma in diabetic patients. So those are specifically for microvascular damage. Alright, eyes and kidney. We talked about Somogy having that hypoglycemic plummet, so down in your blood sugar, and then rebounding back up. So of the medications that you can treat diabetes or DM with, diabetes mellitus with, the difference in DM1 and 2 is that in DM1, diabetes mellitus 1, you will not typically treat with oral antidiabetics. Diabetics, there's different types, like metformin and stuff, but they help with the production of insulin or, help your body produce insulin at a better time or whatever. But in DM1, you don't really have a production of insulin, so there's no point of taking oral antidiabetic. So that's why oral antidiabetics are not typically a treatment for DM1. So in DKA, we talked about DKA, diabetic ketoacidosis. We talked about it having metabolic acidosis, having ketones, fat breakdown, but you will not see hypoglycemia during this. If anything, it's the opposite, super high hyperglycemia. So there will be like no rebound in DKA, it doesn't plummet down, unless of course you treat it incorrectly, but there's no hypoglycemia in DKA. Okay, so it's not a symptom, DKA. So we know those three P's for DM: polydipsia, so excessive thirst, polyuria, excessive urination, and polyphagia, excessive hunger. Those three P's. So your patient who's presenting with signs and symptoms of DM will probably say like they're just drinking uncontrollably, but they still feel thirsty, which would be like polydipsia. All right, so drinking uncontrollably and the thirst has not been quenched is a sign of DM. Okay, a hysterophalangography, which are basically just checking the patency of your fallopian and uterine structures. It can be painful, but it's just checking the patency of the female structures.
Can you say that again?
Hysterossalpingography. Hystero, like uterine, S-H-Y-S, sorry, H-Y-S-T-E-R-O, salpingography. Okay, hysterouterine salpingography, fallopians. So it's basically the female tract. You're just checking the patency of it. So you have in PID, you can see lower abdominal pain, cervical tenderness, purulent drainage, and elevated ESR and CRP levels. So C-reactive protein. All right, that's different than your other, I guess, inflammation or cancers in the female tract because the discharge, that's something you don't typically see. That's in pelvic inflammatory disease, especially if you got it from an unresolved STI. So you'll see that drainage, and then the CRP, because typically that's in like, you see it when you have like heart issues, but it's like the destruction. Like whenever there's like pain or severe destruction, you can see C-reactive protein. So you wouldn't just see that in typical swelling, or typical like ovarian cancer. That's specific to PID. Elevated ESR, elevated CRP, of course lower abdominal pain, the cervical tenderness, and then purulent drainage. Okay. So basically to distinguish that your patient is going into menopause during the pre-menopause period or the period before menopause, they're not having their period or amenorrhea, this should be tracked over the course of 12 months. Okay, that's to distinguish between other things like stress or hormones or medication. So if you don't have your period or amenorrhea and you're at an elderly age around 50 for 12 months, that's the sign that you're going to menopause. Right?
Yep, know all about that. Sorry.
Sorry. So we talked about PID. So typically, like I said, unresolved STIs lead to PID. So that typically chlamydia and gonorrhea. Other STIs could cause it as well, but typically looking at chlamydia and gonorrhea being risk factors to PID, which is then a risk factor to cervical cancer and ectopic pregnancies. But yes, PID typically from unresolved chlamydia and gonorrhea. Yeah. So BPH, benign prostatic hyperplasia, non-cancerous, typically will happen in elderly men, African American men. So your 65-year-old male is around an age you'll be looking for, and then you'll have increased urinary frequency and dribbling. So basically, dribbling is resolved from you just can't completely empty the bladder because that whole passageway is being obstructive. So it'll trickle out a bit. You always feel like you need to go. There'll always be like more. And yeah, it's a sign of BPH. Okay. Major risk factor of testicular cancer is cryptorchidism. So basically, it's undescended testicles. So they're back up where they shouldn't be. So that's a major risk factor of testicular cancer. Okay. Hirsutism, Hirsutism. That's like the abnormal hair growth in the face, in the body for a woman who has PCOS, polycystic ovarian syndrome. All right. So it can be many places, but obviously, the face is pretty distinguishing. Hirsutism, so that abnormal hair growth and PCOS. This thing kind of looks like hair, like hirsutism, but hirsutism. Okay. So like early signs of ovarian cancer. So you would not see heavy menstrual. A lot of the like female pathologies or other cancers, you might see that in, typically like any reason, but you wouldn't really see it in ovarian cancer, heavy menstrual. That's not going to be a sign in ovarian cancer. Okay? Not too much about males. Our primary sex hormone, testosterone, of course. And then primary risk factor for prostate cancer will be being black. Sometimes, right? For prostate cancer, primary risk factor. So signs and symptoms of testicular cancer could be a palpable mass that doesn't have pain. You can have a feeling of like fullness, so like swelling in the testicular region. There are a lot of signs and symptoms that can come with testicular cancer. So if you was to ask you about that, I would answer all the signs and symptoms. So you have a patient who's elderly with hot flashes. We spoke about that. That's the 12 months of amenorrhea. Causes of erectile dysfunction. Okay. Also a lot of causes. So if there are options for that, I would select all of them. It can be, as you guys probably know, it can be mental, like you just can't perform, or you're sad. Like every medication, especially antihypertensives, can cause erectile dysfunction, imbalanced diet, lack of sleep, stress. There's so many reasons. So I would hit them all for erectile dysfunction. Okay. So we talked about microvascular NDM, and that was the eyes and the kidney, smaller vessels. So if I ask you about macrovascular or larger, you would not select anything to do with the eyes. Okay. Not macular degeneration, not retinopathy, because obviously there's small vessels going to the eyes. So those are microvascular incidents or injuries caused by DM. Okay. Macro would be like things like you have excessive sugar in the bloodstream. It can cause even scarring of like your greater arteries and stuff like that. Reduction in flow. Those are more macrovascular changes. But when it gets to the eyes and when it gets onto the kidneys, it is now micro. Okay. So we know all or the many risk factors of diabetes mellitus, from genetic to activity to diet. So many reasons why you could have DM, obviously diet and activity being some of the highest, but pre-puberty is not a risk factor. Okay? Being prepubescent is not a risk factor of DM. Okay? You can get DM type 1 early onset, but those are not risk factors from diabetes mellitus. I think back in the day, people thought it was just because you got DM type 1 early, so they were worried about kids getting it, but no, that's just, you never had the production from the beta cells to begin with. So that's why you would see it in kids, but that is not a risk factor, being a kid or prepubescent. Diabetes insipidus, we talked about how you have polydipsia, polyuria, and severe dehydration. So no severe dehydration again. All right, we talked about BPH, benign prostatic hyperplasia, and prostatic cancer. To distinguish the two, the best distinguishing factor would be a biopsy. just like with most cancers, you're gonna biopsy or get a sample of the tissue. Alright, so I know we talked about elevated, or she probably talked to you guys about elevated PSA levels in prostate cancer. But that's kind of, yes, that is a very good indicator. Your PSA levels are increased, but the most sure and hallmark diagnosis will be through biopsy. Because you're literally looking at the cells and being like, yeah, that's cancerous. That's not. Versus an elevation is highly suspect. So the best distinguishing test between BPH and prostatic cancer will be a biopsy. Okay. Then probably have to follow up in a bit because she is going to go more in detail about macular degeneration and otitis media, specifically signs and symptoms. I think risk factors as well. So you can start looking at those for macular degeneration and otitis media. But otitis media is really simple, like ear infection. So it's like greater risk factors will be in children just because of the inner ear canals, the structural change in children. You can have like vertigo, you can have drainage, a lot of signs and symptoms, but I'll wait to see what she says specifically. And the macular degeneration can happen over time with age. You shouldn't see like flashing lights. So that's not like something to be like, oh, okay, it's just part of macular degeneration. You see flashing lights, you want to go to your doctor about that. But I'll wait till she gets settled with those, and then we can follow up with those two specific topics at a later point. Okay. So that's basically all I have for you guys. So any questions on this? No? Okay, so you guys, I think you're muted.
No, I need to finish reading the chapters. I haven't finished.
But yeah, so if you guys have specifics or you want to touch on stuff later, just let me know. But I'll let you guys know when she gives me more about macular degeneration and otitis media. But I mean, you can look at it, but obviously you want to be as specific or close to what she's looking at as possible. But they're not really hard to distinguish. Otitis media, besides tinnitus, is like the most common issue with the ear. So I mean, but yes, it'd be nice to know exactly what she wants. So when she talks to me, I will talk to you guys.
Awesome. Thanks so much, Daniel.
For sure.
Thank you.
All right. Hope you guys feel better.
Thank you.
Have a good night. No problem. See you guys.
Bye.
Bye.
Thanks.